I've been asked to talk about the surveillance of vascular access, its importance, and its impact. So without further delaying, I want to disclose that I am a member of a medical advisory board for Vascular, which is a surveillance tool used for vascular access surveillance. I hope to talk about the vascular access surveillance as it is defined, and also want to bring up to date with the new KDOQI guidelines, which came out, and it's what it is saying about the surveillance as we know of. The area of focus for the future surveillance programs will also be discussed. The dialysis access, as we know, comes in different shapes and sizes. And what we conventionally talk about the dialysis access surveillance basically deals with only the fistulas and grafts, including the hero graft is again a combination of graft and catheter, and none of the regular surveillance methodologies actually fall into that. We'll not talk about the PD catheter today. The arteriovenous axis, especially the fistulas, they go through multiple phases. So a surveillance program or any kind of a monitoring program which only looks at one aspect of this axis life might not truly do justice for the axis and its ultimate objective of any surveillance program, which is the outcomes of the axis. So in my, we like to divide the surveillance into post-creation surveillance, where we are evaluating for maturation and other things, which again, an ultrasound would be the greatest tool for that. And the clinical use surveillance, which conventionally, when we talk about monitoring surveillance, that's what we are dealing with once a fistula is mature and is usable. The public health definition of surveillance is to be honest with you, it's a very, it's quite different from the actual surveillance word that we use for vascular access. But few things which does incorporate is any surveillance tool should be an early warning system. Early warning system for what? That we'll talk about. And also it should document the impact of an intervention and track the progress. That means you need to have a continuously, you need to continuously observe and track what your outcomes have been coming through. So in the conventional vascular access surveillance, the word surveillance or monitoring is mainly looking at a very narrow spectrum of a single aspect of vascular access dysfunction, which is a clinically significant stenosis. Now, how do we define a clinically significant stenosis? It's mainly by it reduces lumen diameter by more than 50%. That's your 50% stenosis that you see on the angiograms or on the ultrasound. It also talks about the elevated resting pressure gradient, and it should cause volume flow reduction. Now, we are putting all our eggs in one basket when we talk about only a stenosis being the main area or main main reason for a access dysfunction. Why? Because, but you may ask, why do you even need to have a surveillance or a monitoring program for our fistulas or grafts? Because, you know, our patients have a bad vein to begin with. They are, they already have pre-existing neointimal hyperplasia. That is, the veins are already thickened even before you create a fistula or a graft. They're not totally healthy veins that we actually deal with. Even when you create a fistula, or fistula, 2/3 or 40% of them may actually not become mature enough to use for dialysis. Now again, that is not something that it varies from surgeon to surgeon and center to center. Now, if you look at even when you get a good fistula, the body also reacts to the formation of the fistula in various forms, and that's your clinical stenosis that we are always concentrated upon, and most of our surveillance tools are looking into. But the other aspects, the other complications which come with the fistula, whether it is a aneurysmal dilatation, uh, arm edema due to a central vein stenosis, or a pure distal ischemia from Steele syndrome, those things are not truly taken into account in when you talk about the actual surveillance programs as defined by a lot of people. So we keep hearing the word monitoring and surveillance. So what is a monitoring and what is a surveillance? A monitoring in real world is something that somebody is actually looking at and trying to see if there is a problem. Whereas surveillance involves a little bit more, and it tries to identify a problem, quantify it, and maybe create a referral pattern. In our situation, the monitoring involves physical examination, using the lab parameters, whether somebody has good clearance, good KTOV or KCN parameters, is there having persistent hyperkalemia and things like that. The physical examination is something that is being highlighted in KDOQI these days. It is a physical examination by someone who is trained and experienced healthcare personnel. But to be honest with you, there is no proper certification or training process for majority of our dialysis nurses. They all learn on hands-on, and maybe some programs have robust training, but many times they're not. Especially if you start having a mixture of both fistulas and grafts, it can start to become a little bit more heterogeneous, and the quality of your physical examination starts to go down. The other most important is the healthcare personnel turnover. You know, the dialysis is a very intensive part of intensive job. Many people may get trained, and after a couple of years they may leave, and now you have new people that you have to train. So monitoring is great if you have a good well-trained people, but not all the time you can rely upon the monitoring part. The surveillance, on the other hand, involves not only the physical examination and clinical indicators, but also some kind of a tool, whether it is your ultrasound, or if you're using measures to look at the access flows, or if you're using pressure-based surveillance tools where there is something additional than a physical finding and a clinical indicator are used. You know, it's very important to understand that even though when we are talking about surveillance, we are tracking surveillance in context of as a supplementation to monitoring, not against monitoring. So the monitoring is the core, is the central, and you can add on additional benefits by using the surveillance programs. Now, switching gears and trying to get back onto the newest one, which is the KDOQI, because this threw a lot of spanner into the wheel, if I have to say, for monitoring and surveillance. It kind of goes against many of the things that we have been taught for years together now. So they defined, again, they recognize that the current monitoring and surveillance is purely restricted around access dysfunction and around a stenosis. They do define the access dysflow as refers to clinically significant abnormalities in AV access flow or patency secondary to an underlying stenosis, thrombosis related complications. So it doesn't take into account the infections, the aneurysms, and various other issues which comes with it. The two main things that I want to highlight is the KDOQI went back and looked at all the published evidence and had a rigorous evaluation of the standard of those publications and coming up with these recommendations. So their main thing is, if you want to identify an axis dysfunction, that means if you want to identify a clinically significant stenosis causing various problems to the axis, physical examination should be the main one. And it has to be done by knowledgeable and experienced health practitioners. And the evidence was based upon publications involving interventional nephrologists and their fellows and and a very limited number of center experiences. While it is true that an experienced health practitioner is core for this recommendation, we don't have any guidance as to how do you assess who's a knowledgeable or an experienced health practitioner is, and how can you standardize their skills. The biggest thing which was highlighted in the surveillance guidelines was they said the monitoring is enough, surveillance is not necessary, right? But they used two different yardsticks for this. The monitoring, they used the yardstick of identifying a dysfunction, identifying a stenosis. But when it came to the surveillance, they looked at surveillance whether it can facilitate patency. So they raised the bar for surveillance programs. They said, just if the surveillance program is there only to identify a stenosis, that's not good enough. You want to make sure that whatever you do with surveillance program, it improves the access patency. And we'll go over some of the hurdles which we come across in this regard, because when you talk about the patency, it's not just about identifying the stenosis, but also the process of care and who is intervening, whether they're doing a angioplasty or they're putting a stent or what they are doing with that. And it doesn't, whether it is fistula or graft, it doesn't really say that surveillance is needed or routine surveillance is needed. And they said that due to low quality of the evidence. And in other words, the monitoring of the vascular access is primary, while surveillance or supplementary and action should not be based solely on the surveillance findings. When you're thinking about a surveillance program, the rationale is to detect and correct stenosis, right? The monitoring will help you to identify if there is a stenosis, but the rationale is to detect and correct a stenosis within an axis before the development of the thrombosis, and hopefully by intervening early enough, you improve the access patency and reduce the risk of thrombosis. This was the rationale that was put in by the KDOQI itself. It's not some other publications which talked about this. The diagnostic value of surveillance for detection of stenosis, the KDOQI does accept that the surveillance methods can detect stenosis. It's just that they have questions about the accuracy and reproducibility, but everybody, the standard of practice of any surveillance program is not to go by one value, but actually to get repeated measurements, whether it is your access flows or your pressures, and then trend it over a period of time and see which way it is going before you intervene. The biggest limitation with the surveillance methodologies that we have is that at what threshold you want to intervene with an angioplasty or stent or any of that nature is not truly validated. We do hear the 600 ml and 400 ml and pressures 0.55, but those have not been validated in a scientific manner in an independent cohort. So that's where the big issue with yes, you can identify with the surveillance, but what are you going to do after that? But if you do want to look for the outcome measures when you're using surveillance programs, you have to understand that it's not just the technology that you use for the routine surveillance, whether it's the access flows, intra-access pressures, or duplex ultrasound. But you also want to have a guidelines or a process of referral which is standardized in your dialysis unit to send them for an intervention. And not just sending them, but you should also keep track of who's intervening on your accesses and how their outcomes have been, whether they're practicing standard of care or not. Because if you're sending to somebody who you think is doing a good job, or they claim that they're doing a good job, but in reality, they are not truly, their success rates might not be truly good. So that you have to keep track of that and intervene and give them feedback saying, hey, buddy, I sent you 100 angioplasties, but you know what, 30 of them did not do well within a week or something like that. So you have to keep that in mind. But one thing is for sure, if you're looking using only surveillance for the identification of stenosis, it actually does a good job. If you use the surveillance with any surveillance methodology. In this one, I've showed the access flows. But if you add surveillance to the monitoring, it does increase your probability of finding a significant stenosis. The area under curve of 0.78 is actually a good number to look at it. But what happens after that is what is more important in my mind. And the KDOQI also recognizes that, and they say, you know, if you have a positive surveillance but no clinical indicator, don't intervene. If you have clinical indicators, whether the arm is swollen, prolonged bleeding, poor clearance, or any of that nature, go ahead and do an angioplasty or whatever you want to do, but don't do it if there is no clinical indicator. But if you use the surveillance program, where you have a surveillance methodology, you have a robust standardized referral pattern, and you have a very strong endovascular interventionalist who is working with you, you can make a difference in the number of thrombectomies or thrombotic episodes in your dialysis units. This is a publication from our own institute where we, before we instituted our vascular access surveillance program, we looked at the total thrombectomies over a period of time in phases of 6 months each. As you see, by the end of 1.5 years, once we introduced the surveillance here, gradually the total thrombectomies came down. That was good for the fistulas improved, were kind of inconsistent, but the graft did make an improvement in the thrombectomies. But again, this is a single center, our own experience in this. So coming down to the ultrasound as a surveillance tool, I totally believe that the ultrasound should be your next stethoscope, or you should give up your stethoscope and use an ultrasound, to be honest with you, for majority of the organ evaluations. Why? Because it's very easy, it's affordable. The point of care ultrasound devices have come along really well, and you can use it at any point in time, whether it is post-creation or during clinical use, and detection of stenosis and even intervention. So this part is even acknowledged by the KDOQI also, where they say it is valuable and it has some special characteristics. Only problem is the current evidence is not robust, and we need more studies and publications using this. So a program like Avatar's SonoLab is a great opportunity for everyone to start using this and collecting the data and analyzing and publishing it to help strengthen the data in support of the ultrasound as a surveillance tool. So the KDOQI does give some kind of a guidance as to what to look for the future, but they also suggest that any monitoring program should be based on training your healthcare personnel. You should pay special attention to your process of care and practice patterns at individual dialysis centers. If you have the ability, the point of care ultrasound would really help in improving the access work. In our program, the Greenfield Health System, which is our dialysis chain, we have dedicated access coordinators. We do use the Vascular as our pressure-based surveillance program, and we have a standardized referral guidelines in sending who to send for an intervention and who should not be sent. In conclusion, I want to say that the surveillance program is at crossroads. There is a strong clinical studies are needed to evaluate its diagnostic value, and population level outcome data is really important. Never forget to have additional surveillance program with infection, access maturation, and access loss. With that,